Okay, we will talk about the patient with eating or weight problems. So let's start with this introduction. Many people are concerned about what they eat and how this affects their body weight and shape. However, some individuals become morbidly concerned with their body image to the point that their life revolves around the relentless, relentless pursuit of thinness. This life-threatening psychopathology needs to be distinguished from other physical, psychiatric, or substance-associated causes of weight loss. So let's take a look on definitions and clinical features. Anorexia nervosa and bulimia nervosa are two psychiatric disorders characterized by conscious and deliberate efforts to reduce body weight. Individuals with anorexia nervosa are significantly underweight, whereas weight in bulimia is generally normal or slightly above normal. What about anorexia nervosa? Anorexia is characterized by overvalued ideas concerning body shape and weight, preoccupation with being thin, and intrusive dread of fatness. As a result, a self-imposed low body weight is maintained at least 15% below what is expected for age and height. In adults, the body mass index is 17.5 kilogram per meter square or less. In children and adolescents, growth charts should be consulted. There is also generalized endocrine disturbance of the hypothalamic pituitary gonadal axis, as evidenced by amenorrhea in post-menarcheal women, loss of sexual interest and impotency in men, raised growth hormone and cortisol levels, and reduced T3. In prepubertal sufferers of anorexia, expected weight gain during the growth period is impaired, and a pubertal event like menarche, breast and genital development may be delayed or arrested. While not always present, self-induced purging, excessive exercise, and use of appetite suppressants or diuretics are often used to enhance weight loss. So here we have the body mass index. So the body mass index relates weight to height and is used as a crude test to assess nutritional status in patients who are fully grown. So the body mass index would be the weight over the height in meters square and the weight in kilograms. Greater than 40 kilogram per meter square, this is gross obesity. Greater than 30, this is obesity. From 20 to 25, this is normal. Anorexia nervosa less than or equal to 17.5. High risk for medical complication less than 13.5. The ranges of values listed above relates to adults and differ during growth and development. A body mass index growth chart should be consulted for younger people. Okay, what about bulimia nervosa? In bulimia nervosa, patients usually have a normal body weight, or weight may even be increased. In addition to sharing similar overvalued ideas with anorexia nervosa, bulimia nervosa is characterized by a preoccupation with eating and an irresistible craving for food that results in binge eating. This is associated with a sense of lack of control and is invariably followed by feelings of shame and disgust. To counteract this caloric load, patients engage in purging, self-induced vomiting, laxative and diuretic use, fasting, or excessive exercise, but can employ a number of ingenious, even dangerous strategies, like misuse of thyroid drugs, diabetic patients refusing to administer insulin. Here we have a book that summarizes the ICD-10 criteria for anorexia and bulimia nervosa. So here we have the ICD-10 criteria for anorexia and bulimia nervosa. Anorexia nervosa, all of the following: Low body weight, 15% below expected body mass index, less than 17.5 kilogram per meter square in adults. Self-induced weight loss, poor caloric intake, vomiting and exercise. Overvalued idea, the dread of fatness, self-perception of being too fat, low target weight, and so on. 4. Endocrine disturbance like hypothalamic pituitary gonadal axis resulting in amenorrhea, raised cortisol, growth hormone, etc. In DSM-5, not all of these are required, so endocrine disturbances are not required for the diagnosis. For patients in prepubertal age, failure to make expected weight gains, delayed pubertal events would be the symptoms there. For bulimia nervosa, all of the following: binge eating, strong craving for food, methods to counteract weight gain like vomiting, laxative, fasting, and exercise, overvalued ideas, the dread of fatness, self-perception of being fat, and low target weight. Okay. Hints and tips. Some patients with anorexia nervosa may also engage in binge eating and purging behavior, which is characteristic of bulimia nervosa. This does not preclude the diagnosis of anorexia nervosa. The key diagnostic difference is that patients with anorexia nervosa are significantly underweight and have generalized endocrine abnormalities. In DSM-5, the difference would be in the significant underweight, without mentioning anything about endocrine abnormalities. So, how to assess these patients? In history, it is important to define the extent of eating disorder, yet at the same time not alienate a patient who might be ambivalent about treatment, focusing initially on the patient's life history, premorbid personality, social circumstances, family, friendship, relationships, and functionality can aid engagement and build rapport. These factors can also be very relevant to the etiology of the disorder and useful in determining appropriate treatment. Later in the interview, it's important to focus on weight and eating. Remember that direct questions may lead to confrontation and denial. And a technique that can be helpful to avoid alienating the patient is to normalize symptoms for the purposes of the interview. The following questions may be useful. For anorexic symptoms, you may ask: body weight and shape can be very important to some people. Do you find that you are quite concerned about your weight? Do you think you are a healthy weight? This is a key diagnostic question. An underweight person who recognizes they are too thin does not have anorexia nervosa usually. A common way of losing weight is to eat less or to exercise a lot. Are these things that you do? You may ask: sometimes when women lose weight, their periods can become irregular or stop. Has this happened to you? So you can notice here, you ask the questions with some normalization of the symptoms. What about bulimic symptoms? Often when people try to lose weight, they have episodes when their eating seems excessive or out of control. Has this ever happened to you? After eating a lot, some people can feel guilty and uncomfortable and can vomit to make themselves feel better. Is this something that you have ever done? Sometimes people might use prescribed or street drugs to help control their weight. Have you ever tried this? And for other psychiatric symptoms, sufferers of eating disorders may report other psychiatric symptoms. Anxiety classically surrounds eating but may appear more generalized. If symptoms are sufficiently severe to be disorders in their own right, then a comorbid psychiatric illness may be present. Distinguishing depression from anorexia is discussed below under the differential diagnosis. Okay. What about physical symptoms? Eating disorders are associated with a number of physical sequelae, and therefore a thorough medical history is required. Physical complications are listed in the box below. Important factors to ascertain include menstrual history, episodes of syncope or pre-syncope, palpitations, tiredness, muscle weakness, and sensitivity to cold. A history of syncope or palpitations is very concerning and places the patient at high physical risk. Again, a history of syncope or palpitations is very concerning and places the patient at high physical risk. So here we have physical complications of eating disorders. Here we have some symptoms that are related to starvation, like emaciation, amenorrhea, infertility, reproductive system atrophy, cardiomyopathy, constipation and abdominal pain, cold intolerance and lethargy, bradycardia, hypotension, cardiac arrhythmias, and heart failure. Lanugo, which is fine downy hair on trunk, and of course loss of hair. Peripheral edema, proximal myopathy, like which is muscle wasting, osteoporosis that may be present as fractures, seizures, impaired concentration, and depression. All of these can be related to starvation, of course. Okay. Complications related to vomiting, like permanent erosion of dental enemas, dental cavities, of course, enlargement of salivary glands, especially the parotid gland, calluses on the back of hands from repeated teeth trauma, which is called Russell's sign, of course, with esophageal tears or gastric rupture. So these are actually serious complications. Laboratory tests like hypokalemia, hypochloremic alkalosis, hyponatremia, these findings that you may find, hyponatremia, hypomagnesemia, raised serum amylase with acute pancreatitis. Okay, in examination, both anorexia nervosa and bulimia nervosa cause medical sequelae, and a physical examination is essential to accurately assess the physical risk to the patient. Patients may be reluctant to be examined. However, this can be facilitated when preceded by clinical interview and in which good rapport is established. Other than measuring height and weight and calculating body mass index, important areas to examine are skin, you look for lanugo hair, fine downy hair on body, loss of head hair, callus on knuckles from self-induced vomiting, which is Russell's sign, dentition, abrasions with tooth decay. Cardiovascular, you may look for lying and standing blood pressure. You may find postural hypotension that may occur if dehydrated, and you check pulse. For abdomen, you look for constipation, and we have red flag here. High-risk examination findings in patients with eating disorders. We have extreme weight loss, body mass index 30% below expected, which is less than 14 in adults. Bradycardia less than 40 beat per minute. Marked postural hypotension, more than 20 millimeter mercury, systolic or postural tachycardia, more than 30 beat per minute increased. Okay. Prolonged QTC, severe dehydration like reduced urine output and skin turgor, hypothermia like less than 35.5 degrees Celsius, unable to get up from squatting position or from lying flat, and confusion, of course. These are serious findings. Okay, so let's continue with the systems for examination. We've talked about skin, dentition, cardiovascular, and abdomen. For musculoskeletal, you may find muscle wasting, ability to sit up from lying and raise from a squat without using hands, the SUSS, sit up, stand, squat test, pathological fractures. Others like core temperature, mucous membranes, you may find them dehydrated, facial glands swollen, especially parotid glands that may suggest frequent vomiting. Investigations. Numerous biochemical and metabolic changes are associated with being underweight and engaging in excessive purging, as summarized in the books. You will talk about them. Okay. These complications may be associated with long-term consequences or result in sudden death. Investigations should therefore include electrocardiogram, urea and electrolytes, full blood count, liver function test, serum glucose and lipids, thyroid function tests, and amylase. Changes in hormone levels, cortisol, insulin, luteinizing hormone, follicle stimulating hormone, and growth hormone have been described. But these are of limited diagnostic value and are not routinely measured. Bone density scan may be considered, DICSA, for identification of osteopenia and osteoporosis. Okay, we have this algorithm to diagnose these patients. Does the patient have a physical or medical cause to account for their presentation? If unsure, investigate and manage as appropriate. If everything is normal, so there is no physical or medical cause, does the patient have another psychiatric cause to account for their presentation? If unsure, comprehensive psychiatric assessment to exclude organic psychiatric illness, substance misuse, psychosis, affective disorder, anxiety disorder, you check for these. If there is no, you ask yourself, if there's any markedly abnormal attitude to body weight, size or shape. If yes, if body mass index is less than 17.5 or the weight is less than 15% expected for weight, if yes, we are talking about anorexia nervosa. If no, is the weight loss is rapid? If yes, we consider evolving anorexia nervosa. We have rapid weight loss, but it is not it's not yet less than 17.5. We consider evolving anorexia nervosa still, but if the weight loss is not that rapid, and we ask ourselves if there is any purging after binging, and yes, so the diagnosis would be bulimia nervosa. So that's it. Here we have a red flag. Hypokalemia is a life-threatening complication that can result from repeated vomiting as well as laxative and diuretic abuse. Hypokalemia. Gradual correction is safer than rapid correction, so advise patients to eat high potassium foods like bananas or use potassium supplements. Severe hypokalemia is an indication for hospitalization even. Okay. Hints and tips. When weighing someone with a suspected eating disorder, always ensure they remove their shoes and any outdoor clothing. It is common for patients to attempt to artificially increase their weight by wearing heavy clothing or accessories, and even to drink a lot of water shortly before review. Okay, what about differential diagnosis of patients with low weight? Here we have a box that lists the other causes of significant weight loss that should be considered, especially when the onset of illness is later than adolescence or early adulthood, because that's not usual. Here we have the differentials. Medical causes of low weight, alcohol or substance abuse, dementia, psychotic disorders, depression, obsessive compulsive disorder, anorexia nervosa, bulimia nervosa, or binge eating disorder. It is very important to exclude physical causes of weight loss, including malignancies, gastrointestinal disease, endocrine diseases like diabetes mellitus and hyperthyroidism, chronic infections, and chronic inflammatory conditions. Note that rare neurological syndromes associated with gross overeating include the Klein-Levin or Kluver-Bucy and Prader-Willi syndromes. Klein-Levin, Kluver-Bucy, and Prader-Willi syndromes. Okay. Poor nutrition often occurs due to self-neglect in patients with alcohol or substance abuse and dementia. Patients with psychosis may not eat due to delusions about food or hallucinations commanding them not to. A negative symptoms of schizophrenia can also result in substantial weight loss due to self-neglect. Severe weight loss may occur in depression, but this is usually associated with a marked loss of appetite and interest in food. Patients with anorexia maintain their appetite until late in the disease and remain interested in food-related objects like low-calorie recipes. Note that patients with anorexia and bulimia often have comorbid depression, and that depressive symptoms may be secondary to the biological consequences of starvation, and thus resolve with subsequent weight gain. Patients with obsessive-compulsive disorder may lose weight when time-consuming compulsions prevent an adequate diet. Also, obsessions of contamination of food might curtail their caloric intake. As with depression, the issue is clouded by the observation that patients with anorexia nervosa have an increased incidence of obsessive-compulsive disorder, which should only be diagnosed when obsessions or compulsions are unrelated to food or body shape. Binge eating disorder is diagnosed in the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition, and in the draft of the ICD-11. In this disorder, people binge eat at least weekly for several months. They feel out of control, distressed, and disgusted during binges. However, they do not then purge themselves or perform any other compensatory behaviors to avoid weight gain. Also, they are not preoccupied with body weight or shape. Hints and tips. In the differential diagnosis of weight loss, anorexia and bulimia nervosa are associated with the overvalued ideas of dread of fatness. Weight loss occurring in depression results from loss of appetite and lack of interest and enjoyment in food. So let's get back to the case. Miss E.D., a 19-year-old law student, eventually agreed to see a psychiatrist after much persuasion from her mother and general practitioner. Her weight had fallen from 65 kg to 41 kg over the previous 6 months, and she appeared emaciated. Her GP had measured her weight at 1.65 meters and had calculated her body mass index to be 15 kg per meter square. The psychiatrist saw Miss E.D. alone and spent some time putting her at ease. After an initial reluctance, she admitted that she was repulsed by the thought of being fat and felt that she was still overweight and needed to lose just a few more pounds. She had stopped menstruating 4 months ago and had also noted that she was feeling tired and cold all the time and was finding it difficult to concentrate. The psychiatrist elicited that she only ate one small meal a day and was exercising to the point of almost collapsing. She denied binge eating or self-induced vomiting, but did admit to use 20 Senna tablets daily. She reported symptoms of depression, but no suicidal ideation. Physical examination revealed a pulse rate of 50 beats per minute and fine downy hair covering her torso. So let's discuss the case. Miss E.D.'s body mass index is 15 kg per meter square, which is more than 15% below what would be expected. She admits to a dread of fatness and consequently pursues a target weight significantly below that which is normal or healthy. Her weight loss methods including poor caloric intake, excessive exercise, and laxative abuse. Dread of fatness, low body weight, and endocrine disturbances like amenorrhea are characteristic of anorexia nervosa. The depressive symptoms may signify a comorbid disorder or be secondary to the biological effects of malnutrition. Medical complications include amenorrhea, lethargy, bradycardia, and lanugo fine downy hair on torso. Her extremely low body mass index, moderate bradycardia, and history of almost collapsing while exercising place her at moderate to high physical risk. She requires a complete physical examination and same-day bloods and ECG to assess for any acute life-threatening complications. She will require urgent treatment to stabilize when then increase weight. Now you can go to chapter 14 to read more about eating disorders and their management. And now we reach the summary for this chapter. Okay. Summary. The key psychopathology in eating disorders is the overvalued ideas of being overweight. Anorexia nervosa is associated with a significantly reduced body mass index, bulimia with a normal body mass index. Purging behaviors are common in both disorders, including vomiting and laxative misuse. Restrictive behaviors are common in anorexia nervosa, including overexercise and fasting. Anorexia nervosa can be associated with life-threatening physical complications, and it is important to perform a full physical examination including muscle power, blood tests, and electrocardiogram at presentation and frequently during treatment. هذا والله تعالى أعلم وصلى الله وسلم على سيدنا محمد وعلى آله وصحبه أجمعين.